Ladies and gentlemen, it's a very good evening and we welcome you to tonight's scientific session. We are privileged to be in company of experts who represent excellence across clinical, surgical and technological domains. Tonight's session brings together decades of experience and innovation, from tackling chronic diseases to surgical frontiers and the rise of generative AI in healthcare. Let's begin an evening of learning, reflection and meaningful exchange. Our first experience will be with the topic of diabetes. Diabetes has been taking this society as an epidemic. The topic is diabetes, tsunami in the making, facts and solutions. Our first speaker is a national leader in diabetes care and policy development, whose work has helped shape the landscape of endocrine health in Pakistan. Professor A.H. Ahmed is Professor and Head of Diabetes, Endocrinology and Metabolic Diseases at Hyderabad Medical Complex, Peshawar. He has received specialty training in UK and holds MRCP, FRCP and FACE credentials. As the architect behind initiatives like Diabetes Prevention Program across 25 districts and the landmark DPS Park Survey, Professor Ahmed brings a population level perspective and how diabetes is unfolding in Pakistan and how we might contain its impact. His talk today, Diabetes Tsunami in the Making, speaks not only to epidemiological urgency but also to pragmatic solutions built on data, access and local innovation. Please join me in welcoming Professor Dr. A.H. Ahmed.
Bismillahirrahmanirrahim. Thank you very much for a very kind introduction. I appreciate that. I am an old man, I'm retired, and I'm now working at Hyderabad Medical Complex, so my apologies if I'm disappointed from that aspect. These are my disclosures. I was asked to give this talk, and I'm thankful to PIMA for inviting me, first of all, simply because I've never been to this meeting, and what is happening these days in the world generally, and what's happening in Pakistan. I think I thought it's my duty to come to a PIMA session. Not knowing the background of the organization, but what it stands for, I'm sure it stands for the causes which we all would like to join. I checked with the organizers of what is my audience, and they told me that it's a general audience. And that's why my talk is not going to be very specific for diabetes, it will be a very general talk, and knowing what my audience is. So the word tsunami, you all know probably in terms of population. China, isn't it? And what's the second largest country?
India.
India, you're right. What's the third largest country? There we are starting. That's diabetes. So if you collect all the people in the world and make a country, diabetes will make a third country. This is such a huge problem. I will try to excel this one, but what we are looking at is the orange bit. And what we see in 2017 here, and what is happening in 2017, in 2045, in the years to come. So the prevalence is increasing. Why should we worry about it? Because most of the prevalence of diabetes, as I said, if you collect all the people in the world, that will make a third largest country in the world after China and India. So it's a huge problem, it's a huge prevalence. This was the last Atlas report. It says 537 million adults are living with diabetes, and this Atlas was published in 2021. We've got a new Atlas coming right now. But the reason I'm showing you this in a minute, I'll tell you. The other reason is 6.7 million deaths happened in 2021 because of diabetes. So it's a huge problem. Why I showed you the prevalence of 537 million, just I want your attention for a little time. Focus here and focus there. So, whatever estimate world organization, champion organizations gave you, these are just estimates. They are not real figures. They are based on the prevalence surveys what people have done. So in 2021, they said that this is 537 million in the world with diabetes. When 2021 came and they checked the estimate, it was actually 784 million. So whatever estimate somebody gives you, it is bound to be an underestimate. And I can for sure say the same about our country, that whatever estimate you've shown us, you've told us about 30% and 25% and whatnot, they are underestimated. In the practice which we do, they are certainly an underestimate. This is prevalence reported by International Diabetes Federation, and part of it was our largest survey. We have done the largest survey to date in the country on 18,886 subjects, and we found the prevalence to be around 17%, but there was another survey from Professor Basit from Karachi, and our both surveys were joined together, and this was the figure given to us, around 21% prevalence. That is one problem. The other problem is there's a lot of population who's underdiagnosed, even more than what we have. And then there's a big number of patients who are uncontrolled, and then you have got another set of population who's pre-diabetic. I can bet here in this hall, if I ask you to raise your hands for people who in the family have got diabetes, can you raise your hands? Anybody? You look around. Everybody has got anybody in the family with diabetes. So that's a huge scale of problems that we have. And then on top of that, there's a pre-diabetes, then uncontrolled diabetes, and then undiagnosed diabetes. So we've got a mammoth task, and that's why unless and until organizations, countries, policymakers are involved, we just cannot control it. I think we have lost it. At least I can say it from my side, we have lost it. We cannot tackle diabetes. I think the only hope that we have, and I would urge every one of you, is to work on your children. Make sure they have a healthy lifestyle, make sure they don't get obese. So this is the problem that we have. Now we all know there's a very narrow margin of hemostasis of glucose which works in the body based on what we eat, what the liver produces, what the muscle produces, how it is stored, what the adipose tissue does. It's a very complex, and I don't want to go back to bore you with all those physiology and biochemistry, but then there is a consumption mostly in the liver, adipose tissue and muscle, and then there's a consumption by the brain, and if there's a deficiency that the ketone produces the energy substrate, and we know what happens when the ketones are produced in the body, and then the pancreas itself is working to store the glucose into the liver. So it's a complex which is happening in the body, but two main problems which happens in diabetes. One is insulin deficiency, or what we call relative insulin deficiency, and the other is insulin resistance. Resistance is mostly due to decreased uptake on muscle, liver cells, and adipose tissue, and there's an increased glucose production from the liver. So even if you don't eat anything, most of our patients tell us, doctor, I will not eat anything. Please don't give me more medicine. I will not. I said, if you don't take anything, even then your liver will produce glucose. It doesn't matter whether you eat or not. So what you need is to target what is happening on the deficiency side, what we call insulin relative deficiency, and what's happening on the resistance part. And these are the two mechanisms which helps maintaining the blood glucose while we are not eating. This is a very interesting slide, and I thought I'll put this here. What we see here is when it is diagnosed. This is the onset of diabetes. And if you look closely, there's insulin resistance which happens way before the diagnosis. And that's why pre-diabetes takes a precedence. We need to identify pre-diabetes, what numbers they are. We need to work on that because it's a resistance which causes deficiency, and it is these two problems which causes the raised fasting and raised postprandial glucose. And then we also know that there is a decrease in incretin action which has been recently, or not recently, maybe 20 years ago, been included in the pathophysiology. So it's important from the management point of view that if you know what is the pathophysiology, you can easily manage the disease. If it is such a easy to understand, why we haven't been able to tackle the prevalence? For that, there's different reasons. But once you've got a diabetes patient, why we cannot control that very effectively? I think one of the major contribution is the doctor itself, the patient, and the system in which we work. There's inertia of that system. So all three have got inertia. If you look at the patients, if I usually tell my patients who doesn't think that they have got a serious disease, and I said, look, if you've got a kidney stone, you'll get pain, and I usually say pain is a blessing from God. It's a blessing because it takes you to somewhere because there's a problem. If there's an appendix, there's a pain. You will go to a doctor. So pain is a blessing. Unfortunately, diabetes doesn't cause pain. And because it doesn't cause pain, because it doesn't cause any symptoms, ordinarily, the patient thinks, well, if I've got 400 glucose, so what? So there's a problem from the patient perspective, and there's inertia to manage that. If it comes to insulin or injection or whatnot, they usually resist it. Then the physician itself, usually doesn't have time to educate patient. You need only a little education for that patient, but we don't have time. And then some of the physicians who are not very keen on giving insulin if that's required or adding a drug, that's another problem that we have. Because a fear of hypoglycemia for increasing the drugs is there from the physician perspective, and that's another issue. And then if you look at the healthcare system, we don't have insurance. We don't have any system to support. This is one of the diseases which in Western country, you will get a glucometer, you will get a free strips, you will get insulin, you will get tablets, everything free of cost, because it's a chronic disease. Unfortunately, in our country, that is not the case, but luckily, it is possible in our province because we are running a project in which we are providing to type 1 insulin and glucometers and strips, and we are providing tablets to type 2 and insulin to type 2 patients. So overall, generally, there's a problem. We all took an oath. The oath which we had at our convocation. And what's the first thing in that oath? What's the first line which says? Anybody? Younger colleagues? What's the first line when you take an oath of when you become a doctor? Yes, I swear. Yes, of course you swear. But what do you say? What's the first line ends up with? Younger doctors. Because you are sorry. The first thing in your oath, Hippocrates, we call it Hippocrates oath. The first thing is, do no harm. We all know that. You may not be able to help somebody because of financial and whatnot, but certainly the one thing which you should do is do no harm. And I put it in a perspective because if you've got a knowledge and you're not applying, you're doing a harm. This is my perspective of looking at things. So we've learned that do no harm. So we have got a knowledge of how to tackle a problem, but we don't put action into it. And I think in that perspective, we are failing. So if to control diabetes, we know it's good because it prevents the complications, but to give one drug to somebody from a physician's perspective, the second drug which is added, it takes 2.9 years on average, generally around the world and in our part, we are as a practicing as well, to add another drug to improve the compliance. Maybe things have changed, which it has because medicines are become slightly cheaper here, and to add an insulin for a patient, it takes around 7 years. This is a study done by Kamlesh Kunti from the UK, where there are a lot of Asian population, and where even the resources are there. But what I'm saying is that physicians' inertia is there. We just don't take an action to help because the patient doesn't have symptoms. Unless they have a pain, they won't bother, the doctor won't bother. So the inertia and coming to do no harm, you know what helps you, you know what you should do, and if you're not putting action into that, knowing that it is a harm, I think we are not fulfilling the oath which we took. Delayed treatment, what it means is if you delay treatment for insulin or for any drugs, the percentage of the targets that you will achieve over the time will be reduced as we go along. There are 3 more ways in which you can control, and probably now there's a 4th way as well. One is doing the A1C, which gives a long-term control, which everybody knows and they should do. And A1C differs from population to population, from type of patient to different patient, that what their target should be. And then there's a postprandial glucose, and then there's a fasting blood glucose. I think it's unfortunate that we only take just one part, maybe a fasting, and we say if the fasting is controlled, we don't want to do anything. But it's a fasting, postprandial, and overall A1C. And there's also another one which is called the continuous glucose monitor. Most of the organizations, the champion organization, they tell what the A1C should be. But apart from reducing the cardiovascular risk in our patient with diabetes, diabetic doesn't die of high glucose itself. They die of a heart disease. They die of a cardiovascular mortality, morbidity. And so strokes and acute myocardial infarction, glycemic improvement is foremost important. Of course, blood pressure, the cholesterol, the activity, quitting of smoking, all are important. But what is shown here is important is the glucose control. So if somebody has got diabetes, we need to ensure to control it. If you look at different countries, this is the percentage of population not controlled. So look at Saudi Arabia, look at Pakistan. This is our own study. Me and Khalid did a study, we already published it. The number of patients who are not achieving the target. So most of the countries are in the same range where we are, and it's very unfortunate. If you reduce your blood glucose A1C by 1%, you can reduce 14% risk of myocardial infarction, 21% of any diabetes-related mortality, and 37% reduction in microvascular complication. It doesn't finish. So any control is good. But 1%, if you came from 13 A1C to 12, you've achieved all this for your patient. It doesn't finish here. If you do it in the initial part of the disease, we have got evidence that 10 years down the road, if you even they benefit after 10 years. So any control is good, and the earlier the control, the effect lasts very long. And these are different studies which have shown the legacy effect, that if you control it initially, your diabetes in a patient, they're going to be controlled, they'll be complication-free for a long duration of time. If we delay the requirement, I've written insulin, but it could be any treatment. I think we know that what will be the risk of different complications starting from head to toe, starting from blindness to cardiovascular disease and so on and so forth. And the risk of infarction and heart failure and all that increases if you delay the control for 1 year intensification. And that's why I keep on saying starting a treatment is not a big deal. Intensification, getting the control to your target level is what is required and is important, because if you don't do that, the risk of cardiovascular just goes exponentially high if you look at the A1C at the bottom. So 1% A1C and the risk goes tremendously high, and overall A1C more than 8% has got 65% myocardial risk. This is about the annual cost. I will not touch that, but most of us know that the psychological impact of amputation is huge. Well, we talk in the financial terms here. So one amputation of a limb will cost about 152,000 per person. That's a direct cost. Forget about the indirect cost. So what we need to do is control the diabetes in terms to reduce the cardiovascular risk, which is reduced by 42%. If we don't control it, 42% it will cost more for the patient, and same applies to kidney and eyes and so on and so forth. Forget about the physical problems that the patient will have. There are different guidelines. These are the guidelines from Diabetes Care, American Diabetes. This is ACE guidelines, and all the guidelines says that you need to individualize the goal, and you need to do it sooner than later. Don't delay the treatments. These are European guidelines, and I've just put that for a reference. So we need to have more clinicians. I just came from College of Physicians, who was taking an exam. Thank you, Jahangir Saab, for allowing Peshawar to be the Center for Endocrinology Examination. We appreciate that. So Jahangir has been very instrumental all the way, and he was my senior, I must say that, my elder brother. We need to have innovative treatments, and we need to improve the patient care. So it's mandatory that we need to have a cardiovascular protection along with the glucocentric approach. So it has to be gluco and cardiocentric approach, and we need to have early complications reduction by giving the combination of anti-diabetic agent. If you control one person, this is what Quran says. You save one life, you save the mankind. I think this is what is required. I thank you very much for your attention.
Yes, they will be so you can give the witness. Thank you, Professor Amir, for such an eye-opening talk on diabetes and its prevalence in our society. It's definitely important that we take care of it. Moving on, next speaker brings a wealth of clinical experience in hepatology and gastroenterology, and he has a particular focus on liver health in real-world practice. Professor Adil Nasir Khan is head of gastroenterology at Ayub Medical College and MDI, Ayub Teaching Hospital, Ahmedabad. He is a core CPSP faculty member and active contributor to Pakistan Society of Study of Liver Diseases. Tonight he will speak on fatty liver, what we need to know, a subject growing in urgency as non-alcoholic fatty liver disease becomes one of the most common silent epidemics in Pakistan. With his diagnostic precision and clinical realism, Professor Adil Nasir offers both awareness and actionable guidance. Please welcome Professor Adil Nasir.
Sorry for the delay. Dr. Munir, he was conveyed that Professor Amir is a retired professor, but after looking at you, he could never believe that you are a retired professor, so he said that he's working in a... So we would like to know that this, what is the reason behind this fitness?
You've got good class.
So, Professor Ahmed was talking about a tsunami, and I will take this tsunami to another tsunami, about a fatty liver. I have no disclosure to make, but I have taken my few slides from Medscape regarding what is fatty liver. First we have to decide about the nomenclature. In early 1980s, it was first known that excessive fat in the liver causes progressive chronic liver disease. But there was a lot of debate regarding the nomenclature of fatty liver disease. They started it as non-alcoholic fatty liver disease, but it was thought that it is too stigmatizing, this non-alcoholic fatty liver disease. The two stigmas associated with that nomenclature were alcoholic and fatty. In year 2020, they took away the word non-alcoholic and it was metabolic associated fatty liver disease. Then again, it was thought that fatty is again a stigmatizing thing. So a consensus was made in year 2023 and they took away the word fatty out of it. And now we have the word measured instead of NAFED. So we have a new nomenclature where we don't use fatty or alcoholic. So we call it now as a metabolic dysfunction associated steatotic liver disease. So steatotic liver disease now is classified as measured when we only have fats in the liver, but if these fats are associated with a progressive disease or inflammation, then we call it MASH, that is metabolic associated steatohepatitis. And if there is alcohol consumption more than recommended dose, then we call it alcohol associated metabolic liver disease. And the fourth type is alcoholic liver disease because it also causes a steatosis in the liver. Prevalence, we don't have exact prevalence of MESL, NAFLD, whatever it is in Pakistan, but we have a data from US where they say that 85 million of US population is affected by this fatty liver disease. And among these 85 million patients, 1/3 of them have a progressive disease. That means that they have advanced fibrosis. Regarding the tsunami related to diabetes, if you add another tsunami to that of diabetes, is that if they have a fatty liver. It is estimated that year by 2040, half of the US population will be having a fatty liver disease in one way or other. How will it impact overall economy of the US? It has direct cost of about 292 billion and indirect cost of 103 billion. So they are the rich nations. I guess and I fear how we are going to deal with this cost, direct or indirect cost. And how does it affect the quality of life? It deteriorates as disease progresses. Physical and mental health, high rate of comorbidities associated with the fatty liver like diabetes and obesity, high symptom burdens, ability to work, perform daily activities, and impact on the social relationship. What is basically NAFLD, MESL, or whatever it is? Whenever we have more than 5% of our liver cells having a fat droplet, we call it the fatty liver. Regarding the pathophysiology of a fatty liver, there are three main factors which have been implicated in the pathogenesis of fatty liver disease. The first one is dysfunctional adipose tissues and the fat we take in. When these dysfunctional adipose tissues cannot be dealt with our body and that the overall function is overwhelmed, these toxic fat species actually generate an oxidative stress and inflammation. The second part of this pathophysiology is gut microbiota dysbiosis. There are a lot of studies going on this, that there is a dysbiosis. That means there is a change in the gut microbiota. The third link in the pathophysiology is genetic predisposition. A lot of genes have been studied for this predisposition, and the most studied and related gene is so far is PNPLA, which unfortunately prevails more and more in the Asian population. So MESL, what is MESL? It's basically a silent disease. Most people remain asymptomatic, just like a diabetes. They will never complain. They will never come to you with a specific complaint until the disease has progressed to advanced fibrosis or cirrhosis. Thus, early recognition of these patients, especially those with a metabolic risk factor, is important. Mortality, definitely we have an associated mortality with a simple fatty liver or a progressive disease. If you look at this graph and you compare a mortality in a general population to simple steatosis. By simple steatosis, I mean that there is no inflammation or progressive disease. Even then, those people who have more fat in the liver, they have a comparatively more mortality as compared to the general population. And as this goes on with the more fibrosis or more inflammation, the mortality goes up. The most common cause of mortality in these patients is basically a cardiovascular death, and followed by a cancer and liver-related deaths. A Japanese cohort with a simple fatty liver, not a progressive disease, they had a 10 times more mortality as compared to those patients who did not have any fat in the liver. So this is really alarming that we are all physicians and most of us are practicing. How many of times, oftenly you see a report with the patient just mentioning a fatty liver. So do we take that seriously? Most of the time we don't take that seriously. We ignore it. Imagine the burden of diabetes and then I'll be sharing the data how much of the diabetic patient have this progressive disease. So you just multiply the mortality the diabetes itself has and the fatty liver adds up to that mortality. Again, patients with fatty liver or progressive disease have a high risk of developing liver fibrosis, and about 15% of those with the progressive fibrosis develop cirrhosis. And MASH cirrhosis increases the risk of not only of cirrhosis but hepatocellular carcinoma, liver failure, and need for a transplantation or liver-related mortality. The spectrum of disease, basically a fatty liver or diabetes is not a single entity, it's a spectrum. It brings a lot of more things associated with it. It starts as a fatty infiltration, and few patients of those with a fatty liver will have a progressive fibrosis. And they will move from a fatty liver to cirrhosis. But the most important thing, this red line, is that few patients without cirrhosis will develop hepatocellular carcinoma. And now, these days, we are observing patients with hepatocellular carcinoma with no other risk factor other than their obesity, diabetes, or fatty liver. NAFLD, NASH, and metabolic comorbidities. If you look at diabetes and NAFLD, these are bidirectional, meaning that if you are diabetic, you are at risk of developing fatty liver. Or if you have a fatty liver, you are at risk of developing diabetes. Now, if you look at the shaded boxes, you will see the prevalence of a fatty liver in these different conditions. If patient is obese, at least half of them will be having a fatty liver, and among those half, 84% will be having a progressive disease. Similarly, if somebody is having some kind of insulin resistance or a metabolic syndrome, 40% of them will be having a fatty liver, and among those 40%, 71% will be having a progressive disease which will be affecting their liver. At the same time, if patient has a hypertension, the prevalence of fatty liver is 39%, but the progressive disease is around 70%. So there is a bidirectional relationship between a diabetes and a fatty liver or a progressive fatty liver disease. Risk factor: who are the patient who will progress from a simple fatty liver to a progressive disease which will eventually lead to a cirrhosis or other complication of cirrhosis? The older age, if the patient has an age more than 50, keep your suspicion high. If a patient has a diabetes mellitus, again there is a high risk. Metabolic syndrome, and unfortunately Asians. Then high blood pressure, post-menopausal women, obese fat, especially if it's more around the waist, and obstructive sleep apnea. These are all the factors, if present in the patient, will lead to a progressive disease. Regarding the bidirectional relationship between diabetes and fatty liver, in this study, a long follow-up of 10 years, what they found, the patients who were just having a simple cirrhosis or fatty liver, among those, at least 80% over the 10-year period had some type of insulin resistance, and 58% of them were actually diagnosed with the diabetes. So you can realize the impact of a diabetes or a fatty liver over the period of time. This slide is only to highlight the last graph bar. If you look at Asian population, we are unfortunate in the term that even non-obese Asians, they are at high risk of developing a fatty liver. At least 36% of the Asian, they will not be obese, but they will still be having a fatty liver or progressive fatty liver disease. So what we need to do? We need to stratify them into low risk, intermediate risk, or high risk. How this will help us? This will help us in prevention of cardiovascular death or progression to cirrhosis. So, whom to screen for fatty liver disease? All the patients with type 2 diabetes, because they have a prevalence around 20%. Medically complicated obesity, or the patient if is having a fatty liver and is consuming alcohol. And most important thing, first degree relatives of patients with fatty liver. They have a prevalence of, in first degree relative, you have a prevalence of around 18% of advanced disease. If you look at this graph, relatives of patients with nephroid cirrhosis, 18% of the patient in this study had advanced fibrosis, and those patients who had cirrhosis related to fatty liver. So they should also be screened according to the guidelines. So American College of Gastroenterology and Endocrinology recommend that all the patients with type 2 diabetes undergo screening for fatty liver or progressive disease, even if their enzymes are normal. Don't look for raised transaminases. Whereas in type 1 diabetes, only if risk factors such as obesity, metabolic syndrome, or elevated enzymes, they should be screened for fatty liver disease. Regarding the prevalence of advanced fibrosis in diabetic patients, if you look at this graph, at least 70% of diabetic patients will have some form of fatty liver. But among those patients, 15 to 16% will have advanced fibrosis. That means F2, F3 or F4 fibrosis. And 6 to 7% will be having a cirrhosis. So all the diabetic patients, type 2 diabetic patients must be screened for progressive fatty liver disease. Risk of fibrosis is having an increased order of advanced fibrosis were associated with the increased age, female sex, and obesity and insulin resistance. So, how should we screen those patients? What is the better modality? What investigation we shall be using to diagnose our patient who have a progressive disease? So, does the transaminases does a job for us? The answer is no. Plasma ALT and AST levels are unreliable in screening for fatty liver disease because they can be normal up to the 70% of patient. The patient will be having a progressive disease, but their transaminases will be normal. So can we just rely on transaminases to screen our patient for progressive fatty liver disease? The answer is no. So we need to do something more. What can be done? Liver biopsy. How many of you would like to go for a liver biopsy? It's invasive, it has got its own adverse events, it's costly. So most studies and guidelines, they do not recommend a liver biopsy to diagnose a progressive fatty liver disease. As I have said that ALT and AST are unreliable, and liver ultrasound just tells us about whether the liver has fats or no fats, but it does not tell us about a progressive disease. So these all investigations are unreliable. So here comes NITs. NITs are basically stand for non-invasive testing for progressive fatty liver disease. These are used for initial assessment and prognostication of our patient. These are biological or based on the liver stiffness. Among the biologicals, we have direct testing or indirect testing. We have a list of direct and indirect testing. A long list of indirect and direct testing. On left side we have indirect testing and right side we have a direct testing. Indirect means they will indirectly tell us about the progressive fibrosis. And in the direct testing, they actually measures the inflammation and fibrosis going on the liver. The right one are costly and not available anywhere. But on the left side, they are easily available and can be done at your clinic at any time. You just need a calculator to do that. Among these indirect testing, the two most common and widely used and acceptable tests are FIB4 and NASH fibrosis score. These all indirect testing, basically, they were developed to identify the patients who are having a progressive disease. And these tests were developed with two values. one value to rule in advanced disease and the other value to rule out advanced disease. The lower value was to rule out advanced disease and the higher value was used to rule in advanced fibrosis in these patients. But in between these higher and lower value, there was indeterminate zone where you cannot diagnose your patient with advanced disease based on these testing. So, what shall be done for that indeterminate zone? Regarding FIB4 testing, it has got a very good sensitivity and specificity with an area under reciprocal curve of about 0.86. It's simple to use and cost effective. All you need to know the age of patient, ALT level, AST level and the platelet count. And your job is done. You can stratify your patient according to this information. It's cheap, easily available. And the recent analysis have shown that it has a sensitivity of 82% and specificity of 92%. While NASH fibrosis score, it includes few other parameters including albumin, BMI and fasting glucose. But this overestimate fibrosis in diabetic patient and obese patient. So once after the initial testing, or your patient is either ruled in or ruled out, what you will do. If your person is with indeterminate or high FIB score, that means FIB, if your patient is having a FIB of more than 2.6, that means high. You will go for a next test to confirm your diagnosis. Among the next tests recommended by the guidelines are either liver stiffness measurement or ELF. ELF is enhanced liver fibrosis test. In general, these non-specific tests or non-invasive tests have a good and negative predictive value, but they have a poor positive predictive value. So we have to use a sequential test. After a FIB4, you need to do another test to confirm the diagnosis of a progressive fatty liver disease. Change हो रहा है स्पीच जी हाँ चेंज अभी भी नहीं हो रहा ठीक चेंज हो जाएगा ठीक तो once you have initially screened your patient with a simple test like FIB4 or NASH fibrosis score, what to do next? American Association of Liver Disease recommend this follow-up. I know this is a very busy slide, but I will try to make it easy for you. आपने पेशेंट का FIB स्कोर किया, ALT, AST, platelet और एज देख के. अगर वो 1.3 से कम है, that means you have ruled out advanced disease. उसे आप प्राइमरी केयर में रख सकते हैं. लेकिन अगर 1.3 से ज़्यादा है और between 1.3 और 2.6 है, that is indeterminate zone. और ये 2.6 से ज़्यादा, that means a high risk. अब क्या करना है कि आपने एक नेक्स्ट टेस्ट करना है जो कि इजीली अवेलेबल है किसी भी सेटअप में, दैट इज फाइब्रोस्कैन. हर शहर में ऑलमोस्ट अब फाइब्रोस्कैन अवेलेबल है, या इनहांस्ड लिवर फाइब्रोसिस टेस्ट वो अवेलेबल पाकिस्तान में भी नहीं है. लेकिन फाइब्रोस्कैन इज अवेलेबल एवरीवेयर। अब अगर उसकी अपनी वैल्यूज होंगी फाइब्रोस्कैन इसी पेशेंट का अगर 8 kPa से कम आ जाता है, that means less than 8 kPa, that means you have ruled out advanced disease, you need not to investigate that patient further. लेकिन if it is more than 12 kPa, that means this patient is at high risk of progressive liver disease. You need to focus on his liver now. So, important thing is you have to do a sequential testing in these patients. Initially a simple FIB4 and then a liver scan or fibroscan in these patients. इसमें जी इधर नहीं होती। तो जो वैल्यूज हमारे पास फाइब्रोस्कैन की या ELF की होनी चाहिए, मैंने आपको बता दिया कि if your patient is having a fibroscan value of less than 8, it's a low risk patient. Your patient is a low risk. And if it's more than 12, it's a high risk patient. But what about 8 and 12? These are the patients who need a liver biopsy or any other testing to confirm the progressive form of the disease. So most of our patients will not like to have a liver biopsy. So do we have any other option available? There has been a lot of talk about the role of MRI in these patients. So what an MRI can do for us in these patients? MRI can quantify the amount of fat in these patients. We know that MRI costly investigation, हमारे बहुत सारे patient afford नहीं कर सकते. लेकिन the good thing is कि liver fat की quantification के लिए we only need a single breath hold MRI. You don't need 30-40 minutes of MRI. A single breath hold and that MRI will tell you everything about the fats in the liver. Normally जो MRI यूज होती है phase in and phase and post phase MRI यूज होती है, लेकिन ये MRI will not tell about the quantity of fats in a patient. उसके लिए क्या की जाती है, एक स्पेशल प्रोटोकॉल डेवलप किया है, उसको कहते हैं हम PDFF, प्रोटॉन डेंसिटी फैट फ्रैक्शन। और ये हमें क्या क्या बताएगी पेशेंट के बारे में? It is expressed as percentage. What percentage of the liver has fats? It is most accurate, reproducible method to measure liver fat, and PDFF histological measurements correlate, but they are not same. It's almost as accurate as the histology. Highly reproducible and recommended by FDA. What type of MRI we need? We simply need a 1.5 Tesla or 3 Tesla MRI to quantify liver fats. इसमें आ रही रकम आगे में भी जैसी साबित हो जाएगी. So after initial testing, fibroscan, and still you have a doubt, go for an MRI. Yes, Vijay. By the time ये कर ले तो now we know how to investigate our patient, और हमें ये भी पता है कि हमने किन चीजों पर rely नहीं करना, transaminases पे नहीं करना. Regarding the management of fatty liver disease, till 2023 we did not have any recommended treatment for a fatty liver or progressive fatty liver disease. So, हमें पता है कि main mortality जो associated है fatty liver disease is basically a cardiovascular death, and we have a large portion of patients who have diabetes. So we need to have a multidisciplinary approach. You need to take in a cardiologist in a loop, endocrinologist to control the diabetes or any other metabolic thing associated with the diabetes, and definitely if you have a progressive liver disease, a gastroenterologist role is there. So a multidisciplinary approach in these patients is a key to success. You have to start early. How early? Right from the womb of a mother. What you can do, that healthy prenatal diet has been shown to decrease the incidence of fatty liver disease. Increase physical activity during the pregnancy, breastfeeding, complementary food timing, unnecessary antibiotics in children has been associated with progressive fatty liver disease. So what you can do in early life, increase physical activity, increase more sleep, and decrease medication that promote weight gain. So start early. Tell your patient to have a healthy lifestyle in their families. So what lifestyle management? The most important thing is weight loss. How much weight loss? That is important. If your patient is obese or class 2 or 3 obesity, to improve the liver fats, they have to lose at least 5% of the weight. But to improve the inflammation, they have to lose 10% of the weight, of their original weight. That will improve or finish the inflammation in their liver. But as we know that in our Asian patient, we are not obese, but again we are having a fatty liver. Even in those patients, you have to reduce a 3 to 5% of the weight. What next? What type of the diet? Mediterranean diet has been advocated in these patients to improve the liver histology, but the simple rule is no processed food. Have as much as unprocessed food in your diet. This will help you. And you have to individualize the plan for each of your patient. हमारे जो both of the patient है, if you tell them have a Mediterranean diet, तो बड़ा मुश्किल हो जाएगा. So you have to individualize your plan और उसके मुताबिक decide करें. Among the medications of मैं एक last जो recently जो use हो चुकी हैं off label और medication उसकी बात करते हैं. We have been using vitamin E, bifidobacterium, liraglutide and semaglutide. ये जितनी भी medicine थी, they improve some fat content of your liver, but इन्होंने fibrosis और उसमें कोई improvement नहीं की. Surgery has a role, but not recommended of fatty liver disease. इसकी एक indication है for metabolic weight loss surgery. उस वक्त तो की जा सकती है, लेकिन सिर्फ progressive disease के लिए surgery नहीं कर सकते. इस पे डॉक्टर जरीन बात करेंगे. Drugs, beta-chloric acid, use हुई है, indicated for PBC and has been used in patients with fatty liver disease, लेकिन it has not shown a clear-cut benefit. Now we have a drug which is approved by FDA in 2024, and that is resmetirom. How good it is? It improves both the NASH and fibrosis. And the third secondary endpoint, the metabolic profile or the liver profile, will be improved. It is indicated, and soon it's going to be launched in Pakistan. Another drug which is in the pipeline and phase 3 trial are awaited report results, that is lentipreneur. It has shown a wonderful results, not only improving the NASH, but fibrosis and the metabolic profile associated with NASH. Semaglutide अवेलेबल भी है, बहुत सारे लोग यूज भी कर रहे हैं. It does improve the metabolic profile, लेकिन NASH और progressive disease पे इसका कोई impact फिलहाल किसी भी स्टडी में नहीं आया. That's all about fatty liver. Thank you.
Thank you, Dr. Adil, for such a detailed perspective on fatty liver. It definitely has become an epidemic. And when you mentioned bariatric surgery, it reminded me of a very dear and near Dr. Zareen. Dr. Zareen has been a pioneer in bariatric surgery and laparoscopic surgery in KPK in general and in Hazara in particular. Our next speaker will be Professor Zareen. He is working as a professor of surgery at Ever Teaching Hospital, Peshawar. And today his topic will be focusing on how bariatric surgery or the approaches to bariatric surgery can change life of patients who are suffering from disease. Please welcome Professor Zareen. This is for so.
Bismillahirrahmanirrahim. Once again, I'm extremely thankful to PIMA for inviting and giving me this opportunity to talk on this important topic. Unfortunately, there is nothing like tsunami and anesthetic activity in this bariatric surgery. It's a simple surgical procedure for obese patients. Briefly, we'll discuss about the history and evolution of bariatric surgery, the global networking and types of bariatric procedures, what are the indications, contraindications of metabolic surgery, obviously pre-operative and post-operative management of it, and future trends and challenges. About the epidemics, WHO reported that in 2022, 1 in 8 people worldwide they have this obesity. Worldwide adult obesity has more than doubled since 1990s, while adolescent obesity has quadrupled since then. Food and Agriculture Organization, there's a repository about that estimated that by 2030, over 1 billion adults over 1 billion adults globally they will be involved by obesity. And for that, every 4th March is celebrated worldwide by WHO is the World Obesity Day. Briefly talking about bariatric surgery, basically it encompasses a group of surgical procedures used to treat obesity and related health problems by modifying the digestive system to reduce food intake and its absorption also. It's also known as metabolic surgery or weight loss surgery. Metabolic surgery or weight loss surgery is not that new. It has become for decades back. And the early procedures were the vaginal bypass, and the first procedure performed an open surgical procedure was in the early 50s, but it got obsolete because of its associated complications. Nowadays there are modern and laparoscopic and robotically available procedures, and we will be discussing that in detail. There are certain international organizations who are monitoring and supervising and regulating the bariatric surgery worldwide speaking. There is an organization by the name of EFSO, International Federation for Surgery of Obese Patients, IBC, International Bariatric Club, American Association, and there are British associations. And similarly, we have recently launched the Pakistani Obesity and Metabolic Surgery Society. Briefly, this is the pictorial picture of what we do to the stomach in bariatric surgery. The first picture shows that band is applied to the proximal stomach, so the stomach is divided into a proximal small portion and a distal bigger. And the two parts of the stomach, they are connected through a narrow channel, and there is a controlled flow of food from the proximal small chamber to the distal bigger chamber, and thus the food control is there, and the patient loses weight in response to that. It was an old-fashioned procedure and almost obsolete now because it involved the technicalities and that had a lot of complications associated with banding. Now the recent procedures available and commonly practiced are the sleeve gastrectomy, in which pretty much a bigger part of the stomach is removed based on its greater curvature. Almost 70 to 80% of the stomach is chopped off, and the remaining stomach is left like a banana-shaped stomach. On one side, the capacity of the stomach is reduced to almost 70-80%, but it's not only about the capacity of the stomach. The part of the stomach, which is ghrelin producing stomach, that's the fundus, that's removed, and the ghrelin is a hormone which stimulates your brain and it increases the appetite. There's another procedure you can see. That's known as Roux-en-Y gastric bypass. Again, the stomach is divided into a bigger stomach and a smaller stomach. The smaller stomach is a proximal part of it, and it's based on the left gastric artery. The smaller stomach is in turn united with the jejunum in a Roux-en-Y fashion. The last procedure is the mini gastric bypass, or the one anastomosis gastric bypass, in which large part of the stomach is separated based on the lesser curvature and left gastric artery from the major stomach, which is based on the greater curvature. The smaller part of the stomach is connected with the jejunum in a fashion like this one, and the food is going into smaller chamber of the stomach, and then it goes to the jejunum bypassing the jejunum, and pretty good length of the small intestine is bypassing it. Basically, sleeve gastrectomy means it's decreasing the hunger hormone. Ghrelin hormone is a hormone which is basically released from the fundus of the stomach, and it acts on your brain, increases the appetite, and it's also known as an orexigenic hormone. So in sleeve gastrectomy, we remove the bigger part of the stomach, and the ghrelin hormone is almost abolished, and so that the appetite is not stimulated, and there is less hunger on the part of the patient. There is less consumption of the food, and because the capacity is also reduced as well as the appetite is decreased. So all these factors collectively they cause in weight loss. This procedure is a very popular procedure amongst the Western population as well as in the American society. This is known as Roux-en-Y gastric bypass. Nowadays, the majority of the surgeons they practice this one. And as I told you that there are certain pros and cons of each and every procedure. This procedure has got mortality of less than 0.2% and a complication rate of less than 5%. It has got a long-term promise of weight loss maintenance. It's excellent for treatment of diabetes and GERD. GERD by itself, it's a very disturbing disease, and in some of the periodic procedures, the GERD symptoms they are worsened or the new GERD developed. So, in order to avoid that, the Roux-en-Y gastric bypass procedure, GERD by itself is treated by this procedure as well as the weight loss is maintained. But it has got some complications associated with this procedure also. And there are high risk of vitamin and mineral deficiencies, high risk of ulcer if taking non-steroidal painkillers also, and if the patient is a smoker. Sometimes there are cases of bowel obstruction because we are cutting the intestine in such a fashion that there are potentially weak areas produced in the mesentery of the intestine, and there are chances of internal herniation into the Peterson and pseudo-Peterson space. So on one side, the internal herniation will cause intestinal obstruction, and on the other hand, adhesions can be another reason for intestinal obstruction. So chances of intestinal obstruction are like 5 to 10% in postoperatively, ranging from 5 months to 2 years. Dumping syndrome, again a very distressing disease after the symptom after the surgery. Another recently popularized procedure by the name of one anastomosis gastric bypass, is also known as mini gastric bypass. It was initially popularized by a surgeon who recently died a few days back, Robert Rutledge. But this procedure was not endorsed by EFSO worldwide so far. And almost 2 years back, this procedure was endorsed and it was recommended as metabolic syndrome for surgery of metabolic diseases. What we do in this procedure that the stomach is divided, as you can see, in a bigger, in a smaller chamber and a bigger chamber. The smaller chamber, which is on the lesser curvature side, is in turn anastomosed to the jejunum in a loop fashion. The capacity of the chamber, or capacity of this stomach will be about like 150 to 200 ml. So the patient can have a satisfaction of intake of food sufficiently, but this food will not be absorbed the way it is absorbed while it goes through the normal channel. The benefit of this procedure, on one side, it helps in reducing the weight, which again is related to so many metabolic diseases and health-related issues. On the other hand, it also helps in reducing and controlling the diabetes. And the mechanism for it is that when the stomach capacity is reduced, food intake is less, but the food pathway is diverted. Food does not enter into the duodenum. As a result of that, the anti-incretin hormones which are released from the duodenum as a response of the nutrient entry into the duodenum will be decreased, and incretin hormones will be increased as a rapid influx of food from the stomach directly into the small intestine. And as we all know that GLP and GIP, the two are commonly the common hormones, and they are pro-insulinogenic and they are anorexigenic hormones. They decrease the appetite and they increase the activity of the insulin. That's how usually these patients, their diabetes is controlled not after losing the weight, but as soon as the patient is discharged home from the hospital because of these hormonal mechanisms. Obviously, there are certain complications again associated with these procedures too. It increases or it develops new GERD because there is a bile will be entering into the stomach, which we have separated from the bigger stomach, and there can be reflux of the bile back into the stomach chamber and back into the esophagus, leading to GERD symptoms. And sometimes ulcer formation, which are known as a marginal ulcer at the site of anastomosis or ulcer formation in the stomach. So sometimes other complications like nutrient deficiencies and mineral deficiencies, again the patient has to be on replacement therapy for that purpose. This was a procedure used decades back for obesity. Adjustable gastric banding, in which a band of commercially available band was applied to the stomach. Initially it was applied through an open surgical procedure, and later on it was applied through laparoscopic or robotic. But it's no more used because after complication is associated with the banding, and the outcome in terms of weight loss is not that much, and that's not that superior as compared to the recent procedures. Okay, bariatric or the metabolic surgical outcomes can also be achieved by other procedures like endoscopic procedures. And gastroenterologists, in that sense, they are helping these obese patients in terms of like intragastric balloon placement. Although it's not a permanent solution, and it can contribute to like 5 to 10% of the weight loss. These are reserved for patients who are not willing for surgical procedures, number one. Number two, those are unfit for definitive surgery, or the patients who are super obese and they are difficult to be managed surgically, or they are next to impossible to operate on them. So temporarily, intragastric balloon placement will reduce the weight to some extent, and they will be suitable for definitive surgical outcomes. On the other hand, you can see intragastric gastroplasty. These are endoscopic procedures in which plication of the gastric mucosa is achieved, and it can reduce the size of the stomach as we do it in sleeve gastrectomy. It's also known as endosleeve, and thus it can help in reducing the size of the stomach as well as reducing the chances of release of ghrelin hormone from the stomach. So it can also help in reducing the weight. Although the studies are still going on and the contribution of endogastric sleeve is still under observation. Obviously, every patient or every obese patient is not a candidate for bariatric surgery. There are certain criteria based on BMI and based on body analysis. For American and European population, any person who has a BMI of more than 40 without comorbidities are considered to be candidates for bariatric surgery. And a BMI of more than 35 with comorbidities like hypertension, diabetes, obstructive sleep apnea, and other comorbidities, they make an indication for bariatric surgery. But for Asian population, the cutoff value is much lesser than that. A BMI of more than 28 with severe comorbidities or more than 33 without comorbidities or more than 35 without comorbidities will be an indication for metabolic surgery. Okay, it's not only the BMI which will make you decide to operate, because you can see people with who are wrestlers with a BMI of more than 40 or more than 50, but they have got this muscle mass, the body, the weight because of their muscle mass. And muscle is a sign of health, it's not a sign of disease. So it's basically the person body fat which is important. Normally we have got person body fat in the body. In males up to 20% is acceptable, up to females 30% is acceptable. If a person has got a weight of 100 kg with a fat of 30 kg in females and 100 kg in males and 20 kg fat in the body, this is acceptable. But for metabolic surgery to meet the criteria, a female with a person body fat of 44% and a male of person body fat of more than 34% makes indication for bariatric and metabolic surgery. Obviously, it's not a single person job, not a surgeon job. A team of doctors, paramedics, and other associated services to make it possible. So the team is comprised of the patient, dietitian, nursing, obesity medicine, educationists, support groups, gastroenterologists, endocrinologists, anesthetists, cardiologists, and other people in the field. After meeting the criteria of metabolic and bariatric surgery, there are no strict contraindications for the patients. Okay, obviously the patient has to be operated under general anesthesia. So any contraindication for general anesthesia will make contraindication for surgery too. With severe cardiopulmonary diseases or some other illnesses which makes them incapable of to be put to sleep. So these are contraindications. There are certain other contraindications like RYGB or Windner gastric bypass is a relative contraindication for patients having celiac disease or Crohn's disease also. People with already established GERD are not suitable for gastric sleeve because gastric sleeve will worsen the symptoms of GERD or there are chances of new GERD development. So GERD, the sleeve is not a good operation for patients having GERD. Pre-operative assessment is the most important step, and there are certain groups of people who can help in pre-operative assessment, like the indications of surgical intervention. They have to be sorted out whether there is a clear-cut scientific indication for surgery or not. Obviously, the diabetic and other comorbidities, they have to be well controlled before surgical. And cancer screening has to be undertaken. Alcohol abstinence for more than 1 year, this is the absolute contraindication for surgical because alcohol consumption can have dire complications after bariatric surgery. And smoking has to be quit at least a month before surgical procedures. Patients, they are usually put on liver shrinkage diet or high protein diet weeks before surgical intervention, because mostly we are working on stomachs and the liver, as Dr. Adil has mentioned, is sitting on top of the stomach at times. It's next to impossible to handle the stomach under the heavy liver. So liver shrinkage diet has to be started before surgery. And patient education is important, proper counseling, and psychological assessment. Post-operatively, these patients, they have to be put in a permanent loop of follow-up. They should not be lost to follow-up because once the patients, they lose weight and they are happy with their new life, they lost to follow-up and ultimately they land in the clinics of doctors like endocrinologists and other specialists with lot of metabolic problems. So before it happens, they have to be properly educated, they have to be followed properly. Obviously, these are surgical interventions, surgical procedures. They have the potential of having complications. There's nothing like zero complication rate. There are only 2 surgeons with a zero complication rate. Number 1 who is not operating, and number 2 who is telling lies. Leak. We are operating on stomachs. We are stapling the stomach. Stomach is not diseased. It's a normal stomach. So there are chances of leak, technical reason or some instrument failures. Stenosis, obviously we are interfering with the normal anatomy of human beings. Bleeding is another complication. Thromboembolic events, they do happen. These patients are high risk for thromboembolic events. We were talking about bands. Bands are foreign bodies. They have got potential complication of leaks, band migration, and band intrusion into the stomach. Intestinal obstruction, ischemia, megaesophagus, and pseudoachalasia. These are complications. Sometimes we reoperate on patients who have already undergone bariatric procedures, and they are known as revision surgeries. Some of the patients, they are primary non-responders. As a result of the first surgery, they fail to lose weight, and they need another procedure or revision of the same procedure or converting to some other procedure. And some of the group of the patients are the ones who are secondary non-responders. They lose weight for a couple of months to years, and they start gaining weight once again after that. So these are the type of candidates. They need to be reoperated, or the reoperation happens because of reoperation indicated because of these complications. They do happen, like intestinal obstruction, stenosis, internal herniations, and some other complications. What's new in metabolic and bariatric surgery? Obviously, this is an era of AI and robot-assisted surgeries. And obviously, every time there needs to be development and progression in the field. There are certain challenges like 15% complication rate is a bit unacceptable. So they need to be reduced to acceptable range. And only 20% of the patients having obesity, they have got access to bariatric and metabolic surgery. So the access has to be increased. 80% success rate, again, it's a bit lower. So success rate needs to be improved than more than 80%. So these are future challenges. So as we doctors who are involved in the field of intervention, be it like surgical intervention or any kind of intervention, we need to be trained properly in that. And intervention training is not nowadays possible in real ORs. There should be a simulatory environment. And for that, we have recently launched an academic forum by the name of Lab. And the purpose of Lab is just training and teaching. Just a few glimpses of the pictures and what we do. Fortunately, we have got state-of-the-art skill lab in the Postgraduate Institute of Hyderabad Medical Complex, and there's this first of its kind in any government setup with low fidelity and high fidelity simulators for each and every field of medicine, not only for surgical and robotic and laparoscopic. And you can see these low fidelity simulators and practices going on. A lot of workshops have been conducted in the field of like endosuturing and endoshaping devices. And obviously, these simulated environment has to be followed by master classes, and you can see that master class in the field of laparoscopic and bariatric surgery. So far, we have successfully conducted 3 of these master classes, where the candidates and participants were allowed to join, to ask questions, lectures, and also hands-on training opportunities. I think it's okay. Thank you so much.
Thank you, Professor Zareen, for such a detailed talk. And I was thinking of, during the presentation that it's better that we focus on prevention as far as obesity and diabetes is concerned, because there are so many side effects, and as Professor Zareen aptly said that only those surgeons who are either not practicing or not yet born don't have any complication rates. So I hope we will all think on that. Our next topic is on the role of generative AI in healthcare. So let's see that what a combination of human and AI symbiosis can do in healthcare. It will be an online session, and our final speaker is a truly interdisciplinary view in this presentation at the intersection of artificial intelligence and public impact. Dr. Agha Ali Raza is a Fulbright scholar, PhD of Carnegie Mellon University, and currently Associate Professor of Computer Science at LUMS. His work in speech and language processing, particularly in undeserved and low literacy populations, has reached over 300,000 users across Asia and Africa. Beyond research, Dr. Raza has taken a leadership role in national AI education, training everyone from civil servants to CEOs in responsible hands-on AI integration. I think we need that teaching here for doctors as well. And in this talk, Human AI Symbiosis in Healthcare, Dr. Agha Ali Raza will be telling us how to make full benefit from this symbiosis. So our online session will be starting now. Over to you, Dr. Agha Ali Raza.
Bismillahirrahmanirrahim. Assalamualaikum everyone. Thank you so much. So, can you please just confirm if you can hear me correctly? There is some echo, I think. Hey, can you hear me?
Yes.
Yes.
Can't see.
Yes, we can hear you.
Oh, okay, perfect. Thank you so much. So, should I begin?
Sure.
Okay, thank you so much, Joseph. So, Bismillahirrahmanirrahim. First of all, great pleasure to be with you. It would have been amazing to come over. मुझे invite आपको नहीं किया था आने के लिए. I really wanted to come over, but I had prior commitments earlier today, so therefore I could not come in person. Inshallah, I'll try in this session to basically go over the basics of AI and how it can be integrated in the human processes, specifically the health processes. To Dr. Saab's point, just one point before I begin my talk, we actually at LUMS, we do conduct such trainings for doctors. Actually, there's going on for doctors right now, which is an 8-session, 3.5-hour 8 sessions where we teach doctors and train them in using AI in regular clinical settings. But yeah, let's begin. Alright, so I'll be playing a video for you. I'm not sure how optimized the whole experience would be because the voice and the video may not be completely in sync, but yeah, let's make do what we can do and then I'll continue after that.
I am not overtrained. And what you see is not. Well, I'll leave it in contemporary terms. That's not. What if I were to tell you that I'm not even a human being? Would you believe me? What is your perception of reality? Is it the ability to capture, process, and make sense of the information our senses receive? If you can see, hear, taste, or smell something, does that make it real? Or is it simply the ability to feel? I would like to welcome you to the era of synthetic reality. Now, what do you see?
Of my talks, there are two reasons for that. One is obvious, that was a deep fake, that was indeed not Morgan Freeman. It was a video deep fake, it was not an audio deep fake, but even with commercially available tools right now, which are free, in fact, some of them, you can produce as convincing audio deep fakes as that. But there is a more important reason. There's a sentence in there somewhere where he says, I'd like to welcome you to the era of synthetic reality. That's the main reason for why I play this video. I'll come back to this point, that what kind of mental image should we have about AI when we're thinking about it, but yeah, that'll be probably close to the end of my talk. So I have three goals today. One, I'll start out assuming that my audience is not very well familiar with AI, which may not be a true assumption, but I'll take this as an assumption just to begin at a point where we are at the very basics. So we'll quickly define AI for ourselves, what AI is and what's not AI. Then we'll take a deep dive down the rabbit hole and see some of the capabilities of AI. Some of these you might already be experts of, and some of these might be interesting and novel for you. But I'll try to just talk about things which you can start integrating in your clinical practices right now. But then, finally, we'll end up with a discussion around what kind of a place, realistically, we see for AI in our lives, in our professions right now. Like, is it coming to replace us, augment us? What does that even mean? So we'll have a quick discussion around that point towards the end. Okay, before I move to the next slide, and because I cannot see you, usually that's a very fun exercise that we do, but let's do a quick exercise. I would like you to ask yourselves the following question. Am I confident in defining the term artificial intelligence? So just ask yourself that question. You don't need to answer the question, you don't need to raise your hands, just ask yourself the question, how confident I am in answering this question about this thing which is so pervasive, like your social media feeds are full of it right now, right? So, am I confident in defining it? And if you are, try to come up with a tentative definition in your head. Okay, by now, hopefully you have either a definition or a clear answer that you don't want to define it. Okay, alright, let's define it. So as with any other field in the world, one of the most controversial or difficult to define things is the name of the field itself. That happened with you guys when you were trying to define life, and for many years it was a challenge. For cognition people, consciousness is still a debatable thing, what it is and what's the seed of consciousness. AI is no different, but for very different reasons. There are many definitions. I'll try to just give you one, which would cover like 98% of what AI is. My goal would be just to give you a litmus test to ask about a particular thing, is this AI or not? Okay. Artificial intelligence simply means the ability to create machines that can learn from experience. That's it. That's all you need to remember. Okay, what is experience in human terms? As an organism, we sample our environment, we act on it, it responds, we learn from it. That whole thing is the experience that as living beings together. Machines can learn like that too. And there is a name for that. When machines learn with their own experience, machines that have the agency to act on their environment, to get a feedback and to see whether they're closer to their goal or not, we call that reinforcement learning. There is another type of machine learning, and similarly for humans, there is another type of learning where we learn from other people's experiences. Like the books that you read or the things that we learn in our class, well, most of them we have not done ourselves before that. So hopefully we have not invented the wheel or discovered fire. So all of that we learn from others. So that kind of learning from other people's experiences, we have a parallel of that in machine learning as well, where a machine is given a lot of experience, we call it data, of humans, and the machine learns from it. So this type of machine learning is called supervised machine learning. So just two definitions done. Supervised machine learning, machines learning from others' experiences. Reinforcement learning, machines learning from their own experiences. Alright? Just one last thing. There is a very common phrase these days, generative artificial intelligence. What's that? So for many years, we have used artificial intelligence just for decision making. Only recently, we have successfully been able to create machines which can also produce new original things. Right now, that new original stuff is in the form of either text, or images, or video, or audio, but it's not limited to that. So tomorrow, if AI starts producing 3D printed artifacts, or starts creating itself, replicating itself, all of that will come under the general umbrella of generative artificial intelligence. That's the first part of the talk. So just the definitions, what we are talking about. Okay, now the deep dive down the rabbit hole. So now what I'm going to be doing over the next 5 minutes or so is that I'll be very quickly talking about use cases of AI that you can start doing right now, and some of you might already be doing that quite often. So let's talk about some of them, and I'll try connecting them here and there with healthcare, with medical science. Okay, first, creative and technical writing. So here in front of you, you see on your left what we call a prompt. You see it color-coded. Actually, when I teach this in my workshops, it usually takes us like 3 hours to get to this point where we evolve this prompt from a very simple prompt, and you reach a point where it starts producing the outputs you want. But here, let me read it out for you. This is just a fictitious prompt. You are a professor of history and space science. You're telling that to a chatbot. Please write a 500-word essay detailing alleged alien encounters and extraterrestrial activity on Earth from a historical and scientific standpoint. Your audience comprises of level students with diverse interests. Please provide references for all facts and opinions. So you take a prompt like this, you give it to a chatbot like your ChatGPT or Gemini or Copilot or whatever, and it's going to produce an interesting essay for you. Obviously, if it's an internet connected chatbot, you can trust its references. If it's not, you cannot trust its references, and even when you can trust its references, then you should be verifying each and every one of them. Now, a simple prompt like that could be used for any of these things that you see on the screen. And this is not an exhaustive list. Like you're writing an essay or a report, an article, or advertisements, or applications, or reviews, or literary art, or social media and communication, and presentations, and so on and so forth. All of that with a very similar prompt like the one that you have just seen. Okay, but that's not it. You can also use similar prompts for writing out your medical notes. So giving your chatbot a few keywords and asking it to write a medical note for you. And following certain formatting guidelines that you're interested in. Treatment and plan according to a particular format. Advanced history taking. So I'll give you a more elaborate example of that later on. But writing in any particular format, that could be augmented with AI in a pretty quick manner. Okay, let's talk very quickly about image generation. You might have already been using this, but I would like to do a fun exercise with you. Okay, read this prompt. A scholarly fox reading a book to a cute bunny, portrait, photorealistic stunning. Now what I want you to do before I reveal to you what DALL-E 3, which comes with ChatGPT, what it created for me, I would like you to envision this. Like in your head, come up with a picture for this. Okay, alright, you have a picture? There it goes. That's what it produced. Whenever I have younger people in my audience, they really love it. Okay, by younger I mean like kids. Obviously, all of you must be young, I can't see you, but I'm assuming. Okay, so let's move on to the second one. This is a slightly tougher one because these things are very less realistic. A lovely dragon monster playing Ludo with cuddly buffaloes. So usually dragon monsters are not lovely and buffaloes are not cuddly, but let's see what it creates. So this is what it created. The dragon monster indeed is lovely and the buffalo, believe it or not, is cuddly. Okay? Here, we asked it to create a gorgeous abandoned mountain fort in a fairy tale forest in Pakistan, and it did. Nicely created. The domes and the arches maybe are indicative of the Pakistani architecture. Here, one of my TAs tried to produce meaning when I was giving a talk. So this is using not ChatGPT but another agent called Flux AI, which is really good at producing humans in its figures. Okay, let's move on to another interesting thing. You see a graph in front of you. Now, if I give you a few minutes, you can stare at it and you can tell me what exactly is happening here. What's the horizontal axis, what's the vertical axis, what do the colors represent, and how do we interpret this whole graph. So I took this photograph, gave it to ChatGPT, I asked it, what do you see in this graph? And was able to accurately, in this case, explain to me what's going on in the graph, what do the axes represent, just from this photograph, nothing more, and even predict the future. I even asked it, can you write out an Excel sheet for me with the appropriate formula so that I can create this graph with my own data? And it was able to produce that for me. Something very nifty and useful for data analysis settings. Here, we were working with a doctor whose one of main tasks, she was a junior doctor, one of her tasks was to take down history. So what you see on your screen is manual history, penned down by her. And she explained to us that one of the things that takes a lot of her time is to go home and to type it up in a nice format. So we took this image from her, gave it to ChatGPT, and asked it to transcribe the image. And then after transcribing the image, we asked it to format it as a medical note. So it was able to do all of that pretty nicely. Okay, then next, I took some images from Radiopedia. These were images of, obviously you are experts and I'm not, so you can probably already see what's going on in the image. So these were images of either fractures or some other situations. We gave it to ChatGPT, asked it what type of fracture it is, and the response that it gave matched the response which was available on Radiopedia. Again, I'm at this point, it almost sounds like I'm selling it, so we wait until the fun part, where I'll tell you how accurate it usually is, or how inaccurate it sometimes could be. But yeah, let's get there. Here I gave it a photograph of a motherboard, and it was able to explain exactly what was on it. I asked it what kind of a processor goes on this motherboard. It gave me a list of options. I asked it where can I buy this from, and it gave me a bunch of options in Pakistan where I can buy this from. You can see, you see where this all is. The whole thing is going. It's going towards the completion of the loop, where my machine is able to figure all of that out and maybe order that for me and it reaches my house. So that loop has already been completed in many settings. Here, I'm using it to explain mathematical equations just after taking a photograph of it. Here it is given a photograph of a deep meaning method. So a book giving CPR who was drowned in his cell phones, and social media comes coming out of his mouth, and hopefully he will survive after that. So ChatGPT was able to see this image and figure out exactly what was going on here. So it's not just quantitative analysis, it's also able to handle qualitative analysis. It's able to tell us that this is Nihari. It's also able to give us the recipe for it. Let's talk about data analysis. Some of you might be interested in that. So you can upload an Excel sheet or a CSV file or some other file of the type, and you can do, just by using natural language, exploratory data analysis, or descriptive statistics, or even more sophisticated things all the way down to hypothesis testing, predictive analysis, or even anomaly detection in your files. Okay, you can very easily build your own custom chatbots. So those bots could be, for example, for your patients, if they are literate, who can come to you after talking to the bot, giving it basic information like what are you feeling, why are you here for, and things like that. Some things like that are being used in hospitals around the world now, in cases where these things are accessible for the patients. Obviously, when we're dealing with low literate, non-tech savvy patients, different techniques could also be tried. Alright, so up until now, we have seen just a bunch of use cases. Now, let's address the elephant in the room. If AI is becoming so powerful, and if you're putting it against the human, let's assume, who will win? Okay, let me ask you a more concrete question. Let's just gauge where we are right now. Suppose if I come up with a new game today, a new strategy game that humans have never known. So I sit with a few people, we come up with a new strategy game, it's not available on the internet. I start teaching that game to a bunch of humans. Suppose it takes off, and let's say 5 years from now, I have a grandmaster across the world, a world champion of that game. Suppose, okay, we have a world champion of a particular game. And now I train an AI using the techniques I have available today and put them against each other. Now ask yourself this question: how many of you would be willing to bet on the human? That the human is going to win? And ask yourself, how many of you would be willing to bet on the machines? That the machine is going to win? Now I can answer this question in multiple ways, but let's go towards the history. The first one is very famous. This is where we lost in Texas. IBM's Deep Blue defeated the reigning world's chess champion, Garry Kasparov, in a 6-game match. So there were actually 2 different matches at 2 different times. First time Kasparov won, and the second time IBM's Deep Blue defeated Kasparov. Okay? Jeopardy. IBM Watson has already been able to beat humans at Jeopardy. Go, which is considered as one of the most difficult strategy games in the world. Lee Sedol, who was an 18-time world champion of Go, in a match, he lost 4-1 to AI. The list goes on and on and on, and this is not a comprehensive list. Select some of these. So we lost to these machines in game StarCraft and Durant experience but very then spotting risks in non-disclosure at 4% accuracy. They achieved amazing accuracy in predicting 3D protein folding structures. An AI system developed by Google Health, it outperformed human radiologists in detecting breast cancer from mammogram images. Okay, so where are we going with this? If AI is becoming so amazing, is it ready to replace us? Is it ready to replace a doctor? Okay, let's look at the other side of the coin. There is something in these modern AI systems that we call hallucinations. A hallucination is essentially just an instance where AI generates results which are unexpected, untrue, but not backed by real world data. So AI can create false content, news or information about people, events or facts. Let's take a few examples. I have many slides, I'll just go over a few. In mid-2023, Microsoft's ChatGPT-backed chatbot, as we know, it's a prominent law professor by inventing a fake sexual assault accusation against him. Actually, one of his colleagues was looking into professors who have been accused of sexual assault. His name came up, and the colleague talked to him that your name is coming up. What happened? That person hadn't ever been in such a situation before. Completely hallucinated fact that was created by the agent. There's another fake reference. Even an article, ChatGPT, create an article, and the sources and the citations that he cited in there, 2 of them simply did not exist, and a 3rd one was misattributed. The whole thing led to a lot of bad fame for him. He apologized later. He issued a statement that he's not gonna trust these references ever again without verifying. Okay, these lawyers were fined $5,000 again because of citing case laws that had never existed. Apparently, they were using these chatbots to create their case. An aerospace professor, Jeffrey Bettel, who was falsely identified as a terrorist by PIN because his name was very similar to another person, Jeffrey Leon Bettel, who was convicted of trying to join a terrorist group. In 2024, this paper, it showed that ChatGPT could invent an entirely new COVID-19 Omega variant with plausible sounding mutations and epidemiology. There is another one where Watson, which is considered as a main AI cognitive agent for cancer care, it produced unsafe and incorrect treatment recommendations in several high-profile cases. So that's why it has been transitioning out fairly quickly. These bots are being used in clinical settings to write down doctor-patient conversations and notes, and again, it has been found that in many cases they hallucinate and incorrectly jots down facts. And similarly, there are many other examples where such problems occur. Okay, I don't think I have a lot of time left, so I'm going to skip a few slides and go right down to the conclusion. So I have a few more things, but I'll just go to the conclusion. What do we learn from all of this? In the first part of my talk, I showed you the strengths, the incredible strengths of AI. The second part of my talk, I talked about things where it can go really, really wrong. So then what's the symbiosis looking like? Well, 3 things that we are learning from the latest research in human-AI collaboration. 1, AI is your partner. It could be an amazing co-creator, but in the end, you are responsible for evaluating and ensuring the quality of the outcome. So you're still relevant, you're very relevant, you're still needed. In fact, this whole thing just completely falls down without the human right now. That's the state of the art. Okay, second, expert prompting and expert validation. There is nothing which can go around that. Now, what does that mean? The person who's having a conversation with the AI to respond to a particular query, that person should be an expert of the thing that it is. For example, if I have a health query, the person who's asking that of your chatbot, that will be a doctor. That way they will know how to ask the question, how to lay out that prompt, and to validate the answer that comes back from AI. So expert is the right person to work with AI, and that interaction does lead to better outcomes, more efficient outcomes, to scaling the whole thing better, to scoping the whole thing better. And then finally, evaluation metrics and benchmarks. Right now we are in a euphoria stage of AI, where like everyone wants to integrate AI into everything. It should not be done that way. You should have very clear metrics, and then you test your models on that and those benchmarks when you're convinced that they are at a point where they could be trusted. Only then those could be unleashed upon your patients or upon the people that they're going to eventually serve. So I'm going to stop here. Thank you so much for your time, and thank you so much for listening to me patiently. If there are any questions, I would be very happy to answer. I'll just remove the slide so that I can see you.
That was indeed a very detailed perspective on how AI can be used in our practice. I agree with that ultimate decision lies with the human who has been using the AI. And I would like to add that AI can only help us if we are master of our field. And if we don't know about our field, then we are going to be misled by AI. And it is very likely that it will create problems for us in our practice. Do you want to add something to it? Mr. Oh, so I guess we have not a lot of time left. I would like to thank you all for attending this scientific session. There was a lot of that has been shared with the participants, starting with a global epidemic that has crept into Pakistan, and now it is becoming a sort of national emergency, followed by a detailed talk by Professor Adil Nasir on how to disrupt the bidirectional association of diabetes and fatty liver disease, and followed by the detailed precautionary tale of surgeries by Professor Zareem. I think we should agree to the fact that prevention is the most important thing. The more we are careful, the more we are expert in adopting a preventive healthy lifestyle, the less we will see the likes of these experts